Morning, everyone. I think Daphne has already summarized everything very nicely. I'm just going to do a quick one for those who did not have time to put in your earphones and just in English. So there's quite a detailed program today. I think today is exciting because we're going to talk about the actual products itself. So we're talking about the EDOF, Elon. We're talking about multifocals, and in this case, the Liberty as well. And Alison's going to talk to us about the add-on. And we're going to have some interaction, hopefully, with you guys, and we're going to try to showcase certain scenarios with some role-playing. I think some of us here will sort of play the patient and doctor, and you're trying to see the interactions and how we choose lenses, and perhaps, you know, something that may be more closer to home as well, when you can use for your own clinics. So today, as Daphne mentioned, there's going to be a little wet lab. For those of you who have not used the Elon or the Liberty or the add-on, there's going to be a wet lab after lunch where you can actually get hands-on and try out the lenses themselves. And I think it'll be useful. So come back after lunch so that you can actually get your hands dirty, get into the nitty-gritty, how to use the different lenses and how they actually behave in your hands. Okay, so I'm going to start off this morning and talk about my initial experience as I was evaluating the EDOF lens, the Elon in this case, and it's a non-diffractive wavefront-linking EDOF IOL. So we're talking about the Elon. Can we have the Slido? Yeah. So I think in our, we're quite used to it in an Asian meeting where, we don't really ask as many questions as our Caucasian colleagues, because I think that's just a cultural thing. We're going to put up the little QR code as well, so if you don't mind scanning it again, you can just pop in your questions along the way and we'll answer them as much as we can. So before I start, just going to put a QR code up. So we're going to have a couple of talks. I'm going to share my experience as I evaluated the Elon in my initial 30 patients. And I think Dr. Wang will talk a bit about EDOF and the Elon as well after lunch. And I think why you heard from Tibor yesterday that, there's an exponential growth in the Medicontur's premium IOLs because Elon has done very well. Isn't that right, Tibor? Elon has done very well. They're oversubscribed. The manufacturer is working hard to actually meet demands all over the world. And hopefully they'll be sending more and more lenses to Taiwan as well coming up. Okay. I think this is one of the things that is very useful in a meeting in Asia where we have some wait for questions to be asked as we go along, because sometimes I find, when you want to ask questions at that time, you tend to not have the opportunity and you forget. So if we can get the QR code up. It'd be the same one as yesterday, I presume. Yeah. Should we just start anyway? Yeah, rather than waste time. We can always ask questions later and during the other Elon talk. Should we do that? No?
We cannot put the Slido on, but we really, really encourage you to speak up and ask the questions. Maybe this is the right opportunity to put up your hands and ask live. So really, please do not be shy, and we're going to answer all of your questions. We try to make the Slido working, but if it's not, just put up your hands. We have the lovely speakers, lovely experts, and don't be shy. Seems like it's going to work now.
No, it's not. It's okay. I think we'll reserve the questions to the end of each talk, and perhaps if you don't have enough time, then perhaps even at the end of the next talk. So we just put my talk up. I think we'll just proceed rather than waste time. I think our talks are going to be so crystal clear that you don't have any questions anyway, right? After all, you know, crystal vision is involved. Everything is crystal. Okay, let's go. Right, so you've already seen this slide, and I'm not going to go through that again because this was still part of the talk from yesterday. Is this the same talk? Yep, so I think already covered, you know, some of the slides I've breezed through because those who were here yesterday, you saw I'm just talking about the problems that we have or the challenges we face trying to implant a multifocal or presbyopic correcting IOL. I think Thibaut very nicely talked about this, so he's the best person to ask about the technology. But essentially, just to summarize, it's a wavefront-linking technology. It's a non-diffractive platform. So, you know, there are many EDOFs in the market. So this is one of the non-diffractive options, and you have a change in the actual curvature as well as in that central 2 millimeters to give you this extended depth of focus that, that Thibaut showed us yesterday. So this is the Elon lens that we're talking about, the different curvatures of refractive zone. I think you've seen that already. So the parameters are here. I think crystal vision, of course, can give you more information, but it is a preloaded lens. It's slightly yellow. And the preloading is quite unique, so I think please have a try. It's got a little drum that actually is attached to the lens, and when you rotate that drum, it folds the lens. It's a good injector, and there's a little bit of a learning curve, but it's not difficult, so get your hands dirty and try it afterwards. So there has been a lot of studies that's come out, I mean, since the Elon has been around for a few years now. And starting out, I think in Europe, you've got data from there. And this is just a typical initial data that was from the European or the multi-center studies. And this is a typical cataract age and, you know, nothing too abnormal. I'm not going to go through the whole table, but this is just essentially to show that the average cataract age and, you know, pretty box standard kind of cataract eyes with no abnormal long or short eyes. But essentially what we're looking at, of course, are the visual outcomes. And my study was looking at binocular outcomes, but of course you want to see how they do as well individually, and you want to see these type of outcomes because what you're looking at is all the percentage of patients 20/20 or better, and you can see that, you know, this got all very good vision because everything on the right side of this chart indicates that they actually have good visual outcomes. This is looking at predictability. So of course, we want a predictable lens, and I think I mentioned yesterday that I'm pretty exclusively using the Barrett formula. And Thibaut tells me as well, if you're calculating for toric, I think they also recommend using the Barrett suite. I think, you know, won't go far wrong with that. So predictability, and you see a little normal curve there, and you want to look at within 0.5 diopters, you see a very nice peak there. So it's all very high numbers, 85%, 82%, which is what we aspire to get. And I think the refractive surgeons, if you look at dry eyes as well, you try to correct for that, you get that extra few percent and you hit towards 90%, which is very difficult to achieve, but achievable. But we all should look at least 80, 85% within half a diopter, and that's what we want to when we talk about presbyopia correcting IOLs. The focus curve, of course, is the actual proof of the pudding, because you're looking at how the lens performs as we are trying to look at the different distances. And the typical way to look at things when you're looking at either a EDOF or any sort of presbyopic correcting lens, you get a nice peak, you get a distance vision, and you should have a gradual deterioration or a sloping downwards of the defocus curve. If you get it nice and flat, and that's where you get a nice elongation of the actual visual focus, and you get nice vision at distance, intermediate, and near. So this is a monocular defocus curve. This is only 10 eyes very early on. I'll show my results later as well. But what you see is that kind of shape that you like. It sounds like a nice flat one, which tends to indicate that you get good vision throughout from distance to near. So this is quite a nice binocular defocus curve, and still small numbers, but these are just initial results. Just trying to show you this before I try to share mine. So satisfaction questionnaires are something that we should endeavor to do. There are so many that are out there, and I'll show what I tend to use, but essentially we're trying to look at the percentage of patients which are satisfied. We look at what their distance acuities are, the intermediate and near, because we are talking about, different or multifocality or elongated focus. And you can see most of the time satisfaction is high. And that's important because we want to put a lens in that actually makes our patients happy. Dysphotopsias are something that we can't get away from. I think even in the lenses where they say non-diffractive in this case, we're still looking for them because whenever you actually mess around or you try to alter the optics to give you elongation of the focus or like in diffractive rings to actually split the light to give you trifocality, you're going to have dysphotopsias because that's what you're doing. You're playing around with the optics and messing around with the light. So we still look for dysphotopsias, and what's important is being present is one, but whether they are bothersome is probably more important, practically speaking. So we always look for whether they are present as one and whether they are bothersome. And you see the scores here, which is whether not at all to one, to slightly or moderately. So everything is a low score. That's a good result in the sense that patients may have dysphotopsias on average, but they're not bothered by it. And this is looking at practicality in terms of visual tasks. So there's a questionnaire that looks at reading, recognizing faces, looking at price tags because that's what we do. We go to the shop to buy groceries, and whether it's safe, walking up and down stairs. When you're driving, looking at doing your hobbies or looking at a TV. These are some of the tasks that we do ask about. And in this case, it does give good visual function. When you see where it's green and you look at, again, the score on the right, when you see most of it are low scores between no difficulty and minor difficulty, then you know that with this lens, on average, patients are able to function quite well on a day-to-day basis. So local data is in relation to my own patients, my patient population. I'm in Malaysia, very similar to people in Taiwan. I think we have Chinese, we have Indians, we have Malays as well. But majority of my practice is dealing with Chinese patients, some of them reading Chinese text as well. So you see that can be quite important to look at. So I'm looking at cases. Initially was the non-toric version. So nowadays I find that when we're actually putting in these lenses, Alison talked about why we should be using toric lenses, how to use them yesterday. And I think we should aspire to, knock Australia off being the toric capital of the world and try to do more toric because it's important, especially when you are trying to correct presbyopia. If you leave out astigmatism, and you're going to end up with less than satisfied patients because refractive error is still going to be present. So I looked, when we started having the toric version, I found that I was able to recruit faster because most of the patients will have some toricity that I will correct. And I think you heard yesterday as well, I don't really have a set point and I say, oh, less than 1 diopter, I think it's fine, less than half a diopter, because there's the impact of posterior corneal astigmatism. So I tend to just input all the patients that are keen to have presbyopia lenses, in this case the Elon, into the Barrett calculator. And if it tells me I need to put in a T2 or a T3 or whatever, most of the time it's going to be T2 or T3, that's the most common, and I just put it in. And if you look back at the keratometry, sometimes it might say half a diopter, but it's against the rule. So it perhaps could be even more than that. And you don't want to be caught out. So that's what I tend to do. I don't have a cutoff point. All patients have that calculated. And if they require a toric according to the Barrett calculator, I'll put in a toric lens. So in this case, I look at a very practical consideration of trying to give them as much as possible spectacle independence. So I give them an offset between half to 3/4 of a diopter in a non-dominant eye. So I'm trying to do a little bit of mini mono. And when I look at this, I tend to try to look at, our biometry does not give us exactly minus 0.75, so it's up to minus 0.75. So if, when they do the calculation, it comes down to about half a diopter, that's what they get. But that's what I plan for in a non-dominant eye. And of course, normal eyes, I'm not looking for any of those post-refractive or glaucoma or epiretinal membrane type eyes. So we're looking at 3-month outcomes. I think sometimes you can look at earlier outcomes, but what I've noticed, when we're doing evaluation for the lenses is from 1 month, you can get some good results, but usually at 3 months, it actually improves further. And more than likely, it's because the dry eye becomes better managed, and it becomes better as well at 3 months. So these are the endpoints, looking at visual acuities at the different distances, and of course the refractive predictability, the focus curve, and all the other questionnaires, as I had highlighted earlier from the previous multi-center studies. So this is the ELON, and so that's the loader. This is the video that comes to teach you how to load, and this is me doing it real time in a patient. So that it does look quite unique. It's not like your typical preloaded, and there is some preparation involved. It's not difficult. You put a bit of viscoelastic, and I must stress, sometimes I've used methylcellulose as well, and I tend to not use methylcellulose now. I use something, perhaps a dispersive or cohesive or something mixed is fine. So that twisting and rolling of the drum tends to fold the lens, and then after that, you remove that tab to sort of unlock it to allow the plunger to then progress the lens into the nozzle and into the eye. So it's not difficult, but there are some steps to follow, and when we start something out, we want to follow those steps before we start, trying our own different techniques, which we do as surgeons. We always try to alter things to make it easier for ourselves. I'm a 2.2 surgeon, so you can see that I'm not able to go in to the eye, but I have a wound-assisted technique. But those of you who are 2.4, I think you'll find that the nozzle goes in easily. Not sure most of you are 2.2 or 2.4, but I'm 2.2. And you can see the lens goes in quite nicely. It's a plunger injector. It's not a screw-type injector, but it's quite a smooth injection. So try that out later. This is how it looks. This is first day post-op. So you do see those two little rings. So it's non-diffractive, but you have the rings. And for that reason, that's perhaps why you might get some dysphotopsias. You see the pupil is still a bit mid-dilated on the first day, but that's how it looks on the first day. Well, there's so many. There you go. Again, similar table. You can see quite a similar age, 67 mean age, and mean astigmatism is not that high. Like I said, most of the time is between T2 and T3s that we put in, which is about a diopter to 1.5 diopters of astigmatism. Pupil size around there, and nothing abnormal really. So pretty box standard cataract patients. So this is the uncorrected visual acuities. So for the dominant and non-dominant eyes, of course, uncorrected, you expect the non-dominant eyes to have better near acuity, which they do. And one of the reasons why I like binocular evaluations is because I find as the most practical situation. I'm not a mix and match person. There are some of my colleagues that like to mix and match. I find there's always some summation, and on average, patients, when they have both of the same lenses in their eye, tend to do a bit better. So you can see very nicely that in the yellow bars are the visual acuities, binocular at 3 months. So that's very good. Uncorrected is almost 6.6, or in 1.0, the decimal, which is, I think, what the Taiwanese colleagues use visual acuities. This is in log bar. So 0.14 for intermediate is about 6, 7.5. 0.2 is it's not too bad. So this is about N5 to N6 if you look at the reading chart, both eyes. And this is with, to remember, an offset in the non-dominant eyes, mini monovision. So this is just best corrected visual acuity. For distance, I think too many transitions. That's why I keep pressing to get the bars up. There you go. Sorry. Oh no, do it again. Can we go back one slide, please? There you go. Visual acuity. So this is looking at best corrected and uncorrected binocular or monocular, especially. Again, binocular, you expect a summation effect. When you talk about distance corrected, you're actually looking at the lens performance. So you're correcting the distance, and you're actually measuring vision at the intermediate. So you're looking at how the actual technology, so to speak, the lens actually gives you intermediate vision. And it's not too bad from the near. So 0.2, 0.3 is about 6/12. And this is the actual, the EDOF part of the optics, and that's what it's doing. This is just spherical prediction. I think you saw earlier chart. It's a little bit like a bell curve. And what you want to see is a nice peak in the center. How many transitions are there? There you go. So this is one place where a lot of the time when we are initially using a new lens, there is some element of a constant optimization required. So I always start off using the manufacturer's constant. You could potentially start optimizing after about 30 eyes. But this is using the A constant. It's not too bad. I think within half a diopter, you see that my dominant and non-dominant eyes is close to 70 plus. Maybe in this case, for my non-dominant eyes, not that great. It's about 65, 66%. And you can see in some cases where they end up more on the plus side, which is not what I want for my non-dominant eyes. They should be more on the minus side. That's what I targeted. So, and that potentially could influence their reading ability because the non-dominant eye refractive outcome was that way. But despite that, I still got pretty decent results. Astigmatic correction, this is just looking at pre-op and post-op and how well the astigmatism is corrected. And in this case, I think I had probably about half or slightly more than half the patients that had toric astigmatic correction. That's a double angle plot. There you go. So this is how we tend to try to assess astigmatism rather than just looking at the refraction. This just assesses by using, again, this is a tool that you can get. I think the ASCRS website has got this double angle plot tool that is free to use. So you put in your Excel data and it plots out this. So I like to illustrate when I'm talking about astigmatic correction because this is pre-op and post-op. It makes sense. It's like a bullseye. So you tend to see all the plots of the pre-op where everything is quite large. And what you want to see is a nice centered bullseye where everything comes towards the center. I think there's still room for improvement. You see there's some outliers. You get everything very tightly within the center. That means that, you know, you have corrected the astigmatism well. And this, of course, whether you correct it well will depend on whether the eye is, the lens is rotationally stable or, of course, whether your calculation was correct in the first place. Now, the centroid will give you an idea of what your astigmatism is like and what your surgery has done. So 0.14 is not too bad. If you get 0.1 or even less, it'd be even better. I looked a bit at rotational stability. So that's pretty good, you know, less than 5 degrees almost 90% of the time. There are some that everything was within 50, and you know that if you go beyond 15 degrees, you know, you start having potentially even induced astigmatism. So it's quite rotationally stable. I think yesterday, I think was it Alison who highlighted that, you know, the biflex haptic just gives you a lot of contact between the haptic and the capsular bag, and that makes it quite stable. Contrast sensitivity, I think I had, okay, looking at photopic and mesopic, and I put in a line of contrast sensitivity just for comparison between a series of patients of monofocal as well as trifocal. There you go. So the yellow is the monofocal. You'd expect the EDOF lens contrast to be standing somewhere between the monofocal and the trifocal, which will come up soon. There you go. So that's the trifocal with, in this case, this was the actual, it's not a Liberty, it's a Panoptix trifocal contrast sensitivity. You'd expect with the diffractive platform, the contrast to be worse. So with the EDOF, it fell right in between the two. I'm trying to advance the slide. There you go. So the focus curve. So dominant eyes, non-dominant eyes, binocular, and I put in a comparison with Vivity because I think I had also done an evaluation for the Vivity lens prior to this using the same protocol. And you can see that that's quite a nice defocus curve, but you would expect with a EDOF lens, it would not be as flat. I think yesterday I did show some defocus curves where, you know, you end up with the trifocal with the reading getting closer to, you know, almost 6.6 or 6.9 around there. So there's some drop off. But in this case, perhaps in my series, you could see earlier, you know, some of them fell on the plus side that would have affected their reading. But on average, I still got, you know, happy patients with about N5 to N6. For some reason, it's taking me at least 20 clicks to get to the next slide. Okay, now, just a quick word. Now, this seems very high. I just need to give you a little bit of a reason why I think that, you know, in my series that, you know, I get very high rates of dysphotopsias with this lens is because the way I test for it. So I'm asking them specific questions, and whether it's the correct or wrong way to do it, you might be trying to sort of over-report it, but really, I'm actually showing them this is a normal scenario. Usually is a car in a nighttime with headlights, and I said, these are halos, and these are starbursts. Do you have this? So when you do that, more often than not, the patient will go, oh, yeah, okay, yeah, let me think about it. Yes, I do. So, almost half or more than half of the time when you specifically ask them that way, they will report halos. But I think what's more important is whether they are bothered for it. So, sorry, I should have shown the previous slide. This is spectacle independence. So they're not bothered. Can I go back 2 slides, please? One more? Yeah. So what I was trying to say is, from the scale of 0 to 4, how bothered they are, as you can see, whether it's halos, glare, or starburst, they're all mildly or not really that bothered on average. So yes, when you ask them specifically, have they got halos and glare, I'm not saying that's how you should be asking your patients. Sometimes you may not want to do that if you're not evaluating a lens, you're just using it in a practical scenario, because you might just be asking for problems when they say, oh yeah, I've got that, and they start having that fixated in their mind. But when I'm evaluating, I tend to do that. But what's reassuring that is they're not really bothered. This was looking at spectacle independence. Also, I've asked them that, if you need it during your day-to-day in the previous week or few weeks since you've had this surgery, do you find that you needed glasses for some of the activities? So, of course, for an EDOF, you see, some of them did say that, yeah, I think I needed, some better near vision, so perhaps a pair of readers would be better. So most of the time for distance and intermediate, there was no issue there. And it's mainly for the reading. And you'd expect that with an EDOF lens, so not completely spectacle independent. And I find that in the scenario of whether they're reading English text or Chinese text, it does make a difference, because the Chinese characters are definitely more difficult to read. So that's one thing I warn my patients about. When you're using an EDOF lens and you're actually going to be reading Chinese text most of the time, then you might have an issue for those really fine print. Okay, I used the VF14 questionnaire. And so this is a series of 14 questions that, all these different activities that you ask about, and whether they have difficulty or they're not able to do at all. So anything that's low, again, between 1 and 2 is good. That means they have no difficulty to mild difficulty. And most of the time you can see that it's actually quite good with this lens. The other thing is also scores. I like this questionnaire because sometimes there's something that you can quantify as useful. So they actually create a score system, and it gives it out of 100. So the average score that most of my patients out of the 60 eyes or the 30 patients is about 95, which is pretty good, 95 or 100. I think that's, you can call it an A star probably. Perhaps you advance the slide for me. My thumb's getting tired. So yeah, okay, so just to summarize now, the Biflex Elon in my hands in this initial 30 patients is definitely a very good option. So I mentioned the fact that my refractive predictability was not up to the standards that I usually have, which is 80+% at least. So you see some of the non-dominant eyes fell below 70% within the target that I wanted. But despite that, I still had pretty decent results, and I think that will be the reason that there could be a very wide landing zone or forgiving in terms of refractive predictability. And initial experience does show very good intermediate distance vision. The near is very functional, and then you hear that word a lot, functional, when it comes to near vision for EDOF, because it is functional. If you want to compare that with a trifocal, you're not going to have the same type of reading. But in this scenario, I was using a 3/4 diopters of offset to improve that, and you could see that most of the patients were able to do their day-to-day tasks quite easily. High satisfaction scores, and the photopsias were not bothersome. Okay, so any questions about the Elon, I think, at the moment? Yes, Dr. Lin. Pass me the mic.
Dr. Lee, thank you so much for your great talk. I have 2 questions for you. The first question is, do you use Elon in the patient post-LASIK and post-refractive? And what's the result? What is your experience? And the next question is, do you use monofocal of Elon in the myopia patient, especially high myopia? And would you please tell us your personal guideline? Thank you.
Okay, thank you for your question, Dr. Lin. So this series were all standard eyes, no post-LASIK. I've used in a couple of post-LASIK patients now, and the results are pretty decent. I think you do need your accurate calculations, and the thing you can't get away from using a good calculator, be it Barrett or one of the other methods. And I think no issues. And I tend to use more EDOF in post-refractive patients. You know, I have got some patients that do use diffractive trifocals as well. I don't really think that's advisable, at least in my hands. But I find with my very limited experience of 2 eyes, one patient for post-LASIK, he was quite a good result, yes, in the sense that he was able to get the reading. And I did warn him that your reading may not be that great, but it was enough for his day-to-day purpose. And mainly the distance has to be important for these patients because they're still quite young. In this case, I think it was probably about early 50s, I think. Perhaps Dr. Wang might have more experience later this afternoon. Or do you want to answer now or elaborate later? Post-refractive Elon?
I have no experience in patient with post-refractive surgery using Elon. But I think this is similar to other EDOF IOLs. If you can calculate the power, I think the successful rate is high. And you should be cautious whether the condition of the cornea is optimal for presbyopia IOL, because refractive surgery, 10 or 20 years ago, the spherical ablation is very high, and the coma, decentered ablation, this will impair the function of the presbyopic IOL. In such situations, I prefer use enhanced monofocal or monofocal IOL with high spherical ablation coefficient. Yes, thank you.
Alison, sorry.
I might just make a comment about post-laser eyes. And in years gone by, have really avoided presbyopia correcting IOLs. But since we've had EDOFs, I prefer to put an Elon or an EDOF in most post-IOL eyes. And that's post-hyperopic treatment or post-myopic treatment, as long as the treatment has not been at the extreme ends. So in terms of the keratometry and the spherical aberration, if you look at that. And they do very well, and I think it's because of that softer landing zone. It's a more difficult group to get the refractive target right because of the previous laser vision correction. And so with a softer landing zone, you're more likely to get them to emmetropia.
Yep, thank you. So I think, you know, we started off talking about how we should not be using it in these eyes as we start out. But, you know, of course, with the experienced refractive surgeons here, that's the first thing they want to ask. Can I use it in these eyes? So I think the answer is yes. I think Alison has a lot of experience with it. I think the Elon does work well. Your second question was with reference to, was it high myopia, you said? Monofocal. Monovision, yeah, in high myopia, yeah. I think we had a discussion yesterday. So I tend to err on the side of myopia. I think for those patients which are highly myopic, and in this case could be anything more than 6 diopters, 7 diopters, we tend to err on the side of myopia. So in this case, let's say I have a very high myope, which I think I had one which is about 8 diopters here, I think in this series. So I would probably make sure that you want to land on the myopic side rather than the hyperopic side. And in this case, perhaps even push it out to -1 or even more, so that, you know, if you do, you know, make a mistake, you will get them more myopic. It's better than, you know, not getting them myopic, because they're so used to good near vision. They're a little bit blurred for distance 6/9, maybe even 6/12, and a lot of these high myopes don't mind that, but they want good reading. So I think I tend to go, I mean, in perhaps more myopia, -1 even or more, sometimes for even the Elon lens, yeah.
Non-dominant eye first, or it's okay?
Actually, I don't have a preference. I just tend to do whichever eye that they came for in terms of the problem. If there isn't what you call a complaint about which eye is worse, or they look pretty much equal, I tend to do the dominant eye first, actually. Yeah, Harvey.
Excellent presentation, Woon Wai. Yesterday, I think Professor Lin mentioned that for myopic eyes, your IOL of choice is an EDOF lens. May we ask your reason for that, and why not use a trifocal lens, for example?
If the patient, his condition is fit for the trifocal, I use the trifocal. But some patient, for example, high myopia with poor retinal condition, or night drive with large mesopic pupil size, I don't use the trifocal. But if this patient is a myopia and even high myopia, I will use the monofocal. Yeah, so not every patient, I think not every patient can use the trifocal.
Hi, thank you so much for the talk, Dr. Lee. Sorry, I just want to ask, because I have a situation whereby my colleague, a radiologist, we are planning to do cataract surgery after this. And because we know that radiologists, they usually work in a dark room. So how do you balance in terms of your aim? You are saying that the dominant eye you are aiming immetrope, and non-dominant eye you are aiming more myope. So in a radiologist, how do you balance between this binocularity and the usage of eye usually in a low light situation? Is there any preference in terms of usage of lenses and the target of the aim of refraction? Thank you.
I think in this scenario, you have decided on an EDOF already, based on not just his work, but other aspects as well?
I think maybe after this conference I will decide,
what to
based
put
on
in.
the discussion that we have today.
But make sure it's got to be either Liberty or Elon, right? Nothing else.
Sure.
I think that's a good one. I think colleagues are always a bit of a challenge. I think as you do more and more and you see more and more patients and you end up with a fellow colleague in front of you, then it becomes, a little bit difficult. I think we're going to get everyone to answer this within 5 minutes before we move on. I think in this case, I would probably, if he's suitable for an Elon, EDOF lens, in the sense that if he's not got too much complaints about, dysphotopsia potentially and working in a darker environment, I tend to find that the Elon, because you get less light loss with the lens, so you might be able to function better if the contrast is not as good. And if you're working with radiology and you're looking at your images and scans, you're looking at the computer anyway, so that's intermediate, and then the Elon works very well for that. For the near part, I think you have to prepare him for that, but the offset, I won't go too much with an offset when it's mini monovision. You don't want him to lose too much stereopsis as well. Because obviously radiologists, they have some interventional things they might need to do. But it's a long discussion is needed. And personally, I tend to err more towards an EDOF lens in this case rather than a trifocal. Yeah. Anything from other colleagues? Alison, what do you think?
Actually, I just wanted to follow up on a previous question, which was the dominant or non-dominant eye, if I might add to that first. And really, I think that's about, for my personal preference, if the myopic patient wants to prioritize distance or near vision. So I'll do, if they want to prioritize the near vision, then I'll do the non-dominant eye first and give them the near vision and see if they, then want to do a mini monovision. If they want to prioritize the distance vision, do the dominant eye, get their distance right and see how they feel binocularly, and then we might be able to boost the near vision in a mini monovision configuration. On to that conversation, I would agree that an EDOF like Elon would be a good choice, because in my practice, I don't find it very pupil dependent, like a trifocal, and everything's more difficult under low light, we know that. So I would either go emmetropia both eyes. It's a very controlled environment to be at a screen reading films. So if they've got a pair of +1 readers there that they need from time to time, I think that that's a good compromise, a good solution and a good outcome for the patient, as long as they accept and you set the expectation for them.
Sorry, so our target is for both eyes immetrope, isn't it? Or which one is better in terms of the preference?
No, I will still go maybe half or 3/4, maybe half a diopter. Yeah, just to get a little bit more reading. Yeah.
Thank you, Dr. Lee.
Okay. All right, I'm going to move on. I think there may be more questions, and I'm great to hear a question from the crowd, so we'll give him a prize for that. Alison, let's get you up here. So she's going to talk to us about the add-on lens. So I think that might be a new concept to, well, at least to me, I don't use many of these, but it's a very good upgrade option, and Alison will tell us how to do that. Okay?